I'm delighted to welcome you to the parallel session on maintaining dementia as a public priority in Europe. We have a number of excellent speakers with us today who are going to present on a number of different aspects of the work that they've been doing, looking at how to ensure that dementia has remained a priority during the COVID-19 pandemic, and looking at how it's maintained within the field of public health as well. My name is Owen Miller. I'm the Policy Officer for Alzheimer Europe, and I won't take up too much time. We have a very full agenda with 5 presentations. So if we have time after each of the presentations, I will take questions. If not, I will move on simply to the next speaker, and we can take some additional questions at the end if we have time. But I would encourage you to please ask your questions in the chat function, and to make use of the opportunity to interact with our speakers. So 3 of our presentations are recorded today, and the first one is a recorded presentation from James White, who has done a presentation on the Alzheimer Society report in the United Kingdom, in England, looking at how people with dementia have been worse hit. So I will ask our moderator if they can play James's presentation.
Hello, my name is James White, and I'm Head of Public Affairs and Campaigns at Alzheimer Society. Over the past 18 months, we at Alzheimer Society have been shocked and saddened to see people affected by dementia hit hardest by coronavirus. More than a quarter of those who died in England and Wales had dementia, which means it's the most common pre-existing condition for coronavirus deaths. Tragically, these effects go beyond the pandemic and will have a long-term level of impact on people affected by dementia. At the end of September 2020, we published a report entitled Worst Hit. This contains an in-depth analysis of just how people affected by dementia have been hardest hit by coronavirus, and what needs to be done in future to ensure the same tragedies don't happen again. Coronavirus has laid bare the dire state of the social care system for all to see, and no one can be in any doubt of the urgent need for the government to act in order to fix it. And more than a quarter of those who died in England and Wales had dementia, which means it's the most common pre-existing condition for coronavirus deaths. The biggest spike in excess deaths was also in people with dementia. Lockdown and the closure of care homes to visitors has left people without vital social interaction and support. The impact of lack of social contact has been huge, leading to faster deterioration in people, a negative impact on their mental health and well-being, and a surge in people reporting feelings of loneliness and isolation. Also, the impact on carers has been severe. Real reports of burnout. We believe that 92 million extra hours have been spent by family and friends caring for loved ones with dementia. When we surveyed people, 95% of carers reported a negative impact on their mental or physical health. And there's real challenges of living with dementia during a pandemic. There's been an increase in dementia symptoms. We also found that care homes were not sufficiently protected from the start, and that there were delays for testing for staff and residents. These should have been in place long ago, long before they were. And also, tragically, the discharges from hospitals to care homes, and this increased the risk of spreading infection due to a lack of proper testing. So, COVID-19 has exposed how our fragmented social care system utterly fails to support people with dementia. The need for social care reform is clear and urgent, and it must be addressed within this parliamentary term. We also believe that national UK governments need to set out a clear strategy to enable people affected by dementia to recover from the effects of the pandemic. This needs to include rehabilitation to counteract the effects on cognitive or physical health, support for people's mental and physical health, and also speech and language therapy, which can be so important to people affected by dementia. This is the only way to combat some of the long-term impacts that is affecting people. We also know that diagnostic services have stopped or suspended, and certain parts of the process have not been available as they should have been through the pandemic. This means that more people are now unable to access the benefits that a diagnosis of dementia can bring. Without diagnosis and post-diagnostic care, people affected by dementia miss out on essential care and treatment, and the period of fear and uncertainty of unexplained symptoms is prolonged. We believe this reduction in timely diagnoses could also have a longer-term knock-on effect on social care, where people diagnosed later require access to care even sooner. In addition, we've seen that since February 2020, there's been a steady decline in dementia diagnosis rates in England. Without this, people are missing out on the care and treatment. And our survey of informal carers supporting people affected by dementia in the community found that 90% of nearly 800 respondents stated that the person they care for has experienced interruptions to their regular health or social care services. The services most frequently mentioned were GPs, dentists, memory clinics, and chiropodists. And respondents to our survey felt that these interruptions had serious consequences. There have also been concerns around end-of-life care, particularly reports of do not attempt cardiopulmonary resuscitation orders, and these being added to the files of people living in care homes en masse without consultation with their families. Also, the sheer pressure that's been placed on the care system has exacerbated existing issues for people with dementia and their carers. An Alzheimer Society survey we conducted of 1,800 carers and people living with dementia showed that 41% of people who received a care and support package had had this reduced or stopped since lockdown began. And we know that the relationship between adult social care and the NHS has been problematic for decades. However, now more than ever, the lack of investment in and long-term reform of our social care system has shown just how it's letting people down, particularly those affected by dementia. I'd also like to say a few words about Dementia Connect. This is Alzheimer Society our core support service, and it has been there for anyone needing support during the coronavirus pandemic. It's offered personalised support to anyone with dementia, their carers, families and friends, and connects people to a whole range of dementia support by phone, online and face-to-face when safe to do so. It's free and puts people in touch with our dementia advisors who offer the support they need, from local help to telephone and online advice. With face-to-face services being suspended due to COVID, we had to adapt to how we supported people. Our dementia advisors made welfare calls to service users at regular intervals to check in and see how people were and to offer ongoing support, so they always had the right support in place. These calls also helped to reduce loneliness and manage the potential worsening of dementia systems. I'm pleased to say our support services were accessed over 2 million times between the end of March 2020 and the end of August 2020, and have helped a huge number of people with concerns during the pandemic. I hope this overview has been helpful, and I would encourage anybody that hasn't read Worst Hit to visit our website, which is www.alzheimers.org.uk, where you can find not only the report, but also a host of other materials. Thank you very much for listening.
That was great. Thank you so much, James, for that presentation. I think a number of the issues which you have raised during that will resonate with people across Europe, and I think indeed was reflected in the presentations that we heard from Jim, from Mia and from Pat this morning. Someone has asked in the chat if the report is available online, but I think you mentioned in your presentation that it is available on the Alzheimer Society website, so we can maybe put a link in the chat for the report as well. I guess too, we have time for a quick question. If there isn't another one in the chat, I might use the chair's prerogative to ask you one, and to ask you, how is this maybe shaping the work which is going to come next for the Alzheimer Society, perhaps in terms of the campaigning work that you're going to do?
Thank you, and yes, good morning, everybody, live and in person. So I think that it's been described as kind of a seminal report in a lot of ways. So we are keen to kind of make sure that the learnings from it are kind of captured and included in our work going forward. It's an exciting time for Alzheimer's Society. in England, Wales and Northern Ireland. We're in the process of developing a new strategy that will be launching sort of in the first half of next year is the plan. And we would very much hope that a lot of what we saw in there is kind of built upon. We're really keen that we do reflect what matters to people affected by dementia, and obviously this report is one such way where we've endeavoured to do that, but it's not a case of kind of job done. So we will be looking to make sure that, as you say, with our campaigning and influencing work going forward, we look to kind of build from it. I mean, we all hope that the pandemic is lessening, but obviously news in recent days suggests that maybe that isn't the case. I hope I'm wrong when I say that, but we will be looking, for example, at opportunities here in the UK when the government has a public inquiry to see how we can reflect the views of people affected by dementia into kind of external influencing moments like that. So, it's been a really useful exercise for us, and it's kind of very timely as we look to shape and think about what kind of organisation we can best be in the years ahead. So, yeah.
That's great. That's really interesting. It sounds like it's going to be it'll be an area of work. And it sounds like a number of countries will be taking such an approach to both for the Alzheimer societies to sort of shape their own work, but also for the governments as well to learn the lessons from what has went wrong in the past and what can be done differently if there are additional waves in the future. I don't see any further questions on the social Q&A. So we finished it perfectly on 11 o'clock. So I'm going to, if I can, move on to the next speaker. So thank you very much, James, for your presentation and for your answer to that question. I'd like to introduce Aine Teahan from Ireland, who is going to speak of work that she's been doing around supporting family carers of people with dementia, looking beyond the pandemic and looking at public preferences for enhanced services and supports. And I think this is a pre-recorded presentation as well. So if the moderator could bring up that presentation, please.
Hello everyone, my name is Aine Teahan and today I'll be presenting some research that I conducted as part of my PhD in the Centre for Economic and Social Research on Dementia in NUI Galway in Ireland. So the findings I'll be presenting are on a discrete choice experiment looking at public preferences and willingness to pay additional taxation for enhanced provision of supports and services aimed at family carers of people with dementia. To give some background, in Ireland, it's been estimated that the total cost of caring for people with dementia is €1.6 billion per year. It's estimated that 48% of this cost is provided informally by family members and friends to people with dementia living in the community, and 43% of this figure is being invested in long-term residential care or nursing home care for people with dementia. And then only 9% is actually invested in formal community-based services for family carers and people with dementia. So, as with many other countries, the onset of the COVID-19 pandemic also marked almost complete cessation of community-based services for both people with dementia and family carers, particularly in relation to home care, daycare and respite services. And this would have resulted in kind of a redistribution of workload from formal service back onto family carers. And despite their increased workload and acknowledging and policy acknowledgement of their increased workload, there really was no solid policy response to supporting family carers to alleviate some of these disadvantages they may be experiencing. So, for example, family carers were not prioritised for additional financial supports, personal protective equipment, and in our national vaccine plan, despite formal carers being prioritised for vaccination before other cohorts, family carers weren't, although they are a group who work quite closely with people with dementia and were providing most of the care to people with dementia who would be considered quite an at-risk group. And really what that reflects in Ireland is that family care is very much viewed as a free resource by policymakers. And moving forward, that isn't going to be sustainable in Ireland. So looking at demographic and demographic changes, we have an aging population, and then other policy moves in relation to aging in place, and also a move towards the dual learner model. Continuing to view family carers as a free resource, it won't be sustainable, and policy really needs to start exploring ways that to support family carers to not only maintain their contributions to long-term care of people with dementia, but also to support their own well-being. This then leads us on to the question of why do public preferences actually matter when considering policy development and increased provision of services to family carers of people with dementia. So I suppose it's very important to consider how any increased provision of services would actually be funded. And currently in Ireland, the majority of health and social care services are funded through general taxation. So it is very likely that any increased provision to family carers of people with dementia would also be funded through general taxation. And this means that the public are actually going to have to pay for increased provision of these services. So in that sense, it's quite important to figure out if the public are willing to pay this additional taxation, particularly as public support for any policy move makes it a lot easier to implement these policy changes. So in terms of the thinking and public attitudes in Ireland at the moment, there has been some research conducted, mainly through citizens' assemblies in 2017 and 2021, which suggests that the Irish public would support increased provision of services to family carers. However, other research has found that although the public may express a preference for something in terms of policy, if they're actually required to pay for this policy change, their support might decrease. So in this sense, it's very important to identify whether or not the public is actually willing to pay for increased provision of services. So in order for us to identify citizens' preferences and willingness to pay, we use the discrete choice experiment, or DCE methodology. So a DCE is a type of specialised survey methodology which asks survey respondents to choose between hypothetical service package alternatives. Would have ranked a long list of supports and services across individual and wider social level, and identified their top priorities for supports and services across individual and wider social supports. And while the design of the DCE survey builds on the preferences identified by family carers in the NGT focus groups, in order to translate these findings into a robust survey design, several additional steps were also needed. The first step involved identifying attributes, so in this case, a specific supports or services, and attribute levels, so how the specific support or service could be delivered. So you'll notice in the table that not all the supports identified by family carers as important were included in the attributes list, and this was necessary for the DCE methodology. So none of the attributes could overlap in terms of the function or the utility that they offered. So for example, monthly wage and carers allowance couldn't both be included. And it's also quite a complex survey. So it's really important not to have too many attributes for survey respondents to choose between. So subsequently, we included daycare, long break, respite, care peer support group, carers allowance, and also an additional taxation attribute, which allowed us to assess, it allowed us to put a monetary value on each attribute. Then the attribute levels for daycare would have included 1 day a week or 2 days a week. Long break respite could be provided in home or out of home. Care support groups could be available once a month, and carers allowance could be universal or not available. So this really was quite an iterative process involving consultation with service providers and family carers throughout the survey design. We also conducted 10 pre-pilot interviews with members of the general public and a pilot with 50 members of the general public to ensure that the survey was understandable and accessible. So after this process, we finalized our attributes and we developed choice cards. Survey respondents had to complete 12 choice cards, like the example given here, which they were asked to choose between two hypothetical support packages, and also package 3, which represents the current provision of services in Ireland. So the DCE findings were analysed using a mixed logit model in the willingness to pay space. And here are the numbers for anyone who's familiar with statistics or econometrics. Including the tax attribute allowed us to interpret these findings in terms of monetary values. So for 1 day of daycare per week, our respondents were willing to pay €338 in additional tax per year. For 2 days, they were willing to pay €448 in additional tax per year. The survey respondents had similar preferences for in-home and out-of-home respite, and were willing to pay €116 in additional tax for care peer support groups. For carers allowance, survey respondents were willing to pay €174 in additional tax annually to extend the current means testing of carers allowance to universal provision of carers allowance. However, there was a very strong negative disutility for not providing carers allowance at all. So in fact, our survey respondents would actually need to be paid €320 per year to support abolishing carers allowance completely. So what these findings show is that the survey sample supports increased provision of all the attributes identified. Increased provision of daycare was most strongly supported by the public. We also conducted some additional analysis by estimating the welfare gain of various packages to citizens per year. So in scenario 1, these findings show that providing 1 day of daycare per week while keeping all other aspects of service provision the same led to a welfare gain of €320 for citizens per year. If you then look at scenario 5, which represents the most comprehensive form of support package for family carers, this represented a welfare gain of €1,035 per year relative to the base scenario of current provision. So combining all the attributes to the highest level of provision available, it yields considerable welfare gains for respondents in this survey. So looking at our findings, what these really suggest, I think, is that there is a mismatch between what the public is willing to pay for and current funding allocations of supports to family carers of people with dementia in Ireland. So although the main limitation of a DCE is that it's hypothetical in nature, our findings do suggest that increased investments in supports for family care is supported by the general public, and they are willing to pay for this increased provision. So family carers, they're often overlooked or seen as secondary in health policy development. But if you look at family carers from a population health perspective, they are a cohort in their own right who experience very significant disadvantages in terms of physical, mental, and financial well-being. And then from an economic perspective, they are the foundation of the long-term care system in Ireland, and they're only going to become more essential in future. So demand for family carers is going to rise, given moves towards aging in place and demographic changes. So it makes sense to start putting support systems in place for family carers, which will address negative consequences associated with caring and also recognise the contribution that they make to the long-term care system in Ireland. So that's it for me. I will be available for questions now if anyone has any. And thanks very much for tuning in, and to Alzheimer Europe for giving me the opportunity to present this research.
What a really interesting presentation. Thank you, Anya, and thank you as well for bearing with us during the technical issues as well. It wouldn't be an online conference without some, so I'm very, very sorry for that. I think the presentation was really interesting. I think often we hear about the resource issue of how much money goes into funding care, goes into support systems is a huge issue, and I think delving deep into how much are the public actually willing to pay for it is a really crucial, I think, explored area. So to see the limit to which people are actually willing to pay is fascinating. We have one question just in the in the chat, which said that the DC methodology is very insightful, and they wondered if you thought there was another way that similar data could be collected.
Yeah, I suppose there are a range of different types of willingness to pay surveys that you can do. Like there is contingent valuation, which would focus in on kind of one scenario or one good. For us, the DCE was probably the best way because I wanted to look at how a package of services could be valued by the public. Yeah, so I think that's it. Like you could look into contingent valuation there. Really, DCE is probably the best practice approach at the moment for looking at public preferences, mainly because you can also compare how different supports are valued in comparison to other supports. So if you look at peer support there, while it was supported by the public, we can also see that the public are willing to pay a lot more for daycare. So yeah, so to go back to the question, contingent valuation is an option. Yeah, if that's all right.
Nope, that's perfect, thank you. So our next presentation is from Clarissa Giebel, who is going to speak about the amplifying dementia as a global public health problem. And she's going to present on a cross-country comparison, specifically on the impact of the COVID-19 pandemic. And I think Clarissa is going to present live, so I hand over to you.
Thank you very much, and it's great to be amongst these presentations. So let me just do the awkward slide share. Today, I'm going to present to you some emerging findings of our 5-country international study. My name is Clarissa Giebel, and I work at the University of Liverpool. And for this particular study, we have been working with, as you kind of see, I've tried to highlight here, with Australia, India, Italy and Poland. And our team is much larger than the people on this slide, but these are kind of the country leads. So we have Dr. Marta Lennart and Maria Markowiak from Wrocław University in Poland. We have Kasia Leon from Griffith University in Australia, Ilaria Chirico from University of Bologna in Italy, and Dr. Suresh Kumar from Kerala in India. So we have been many more people, but just to kind of introduce our team a little bit, because they've done an awful lot of work as well. So as the title of this presentation is Amplifying Dementia as a Global Public Health Problem, it has been highlighted so much that it is of worldwide concern. We have an estimated 55 million people currently living with dementia worldwide, and the numbers are just rising. So it is really important to find adequate care solutions for people. And with the pandemic happening and face-to-face restrictions having been in place now for nearly 2 years, coming up to it, very early on in the UK, we were thinking this must have some sort of impact because people living with dementia are in need of that face-to-face support. And specifically, when we look at different types of face-to-face support that people with dementia, but also unpaid family or friend carers should, in an ideal case scenario, receive. And we know there are lots of inequalities there, so not everyone receives the care they should get. But the types of social support services, social care services that people with dementia should receive, as the previous speaker was referring to as well, for example, daycare, respite care, also paid home care, befriending services in the UK are very popular, for example, from the Alzheimer Society. Support groups in the community and social activities in the community. So really staying socially active, staying socially engaged, but also receiving that care. And many of them are provided outside in the community, but also obviously with paid home carers and befrienders, they come into your home. So we thought really early on, because I was involved in a number of studies when the pandemic started, and suddenly, because I do a lot of co-production, public involvement, unpaid carers were saying to me in our meetings and outside of meetings, like, oh, I suddenly can't get the care anymore, I'm really worried about this. So we were lucky enough to receive some very quick funding within a few days of the national lockdown in the UK on the 23rd of March last year. And it allowed us very swiftly to explore the impact of face-to-face restrictions on people living with dementia and on unpaid carers, and the types of care they receive, but also on their day-to-day life. So we conducted a parallel mixed method study, obviously all remotely, which took some time to get used to, but we conducted in April 50 baseline interviews, and then 3 months later 20 follow-up interviews. Those interviews were with a mix of unpaid carers and people living with dementia from across the UK. Simultaneously, we also conducted a 3 time point longitudinal online and telephone survey, because we thought that many older people might not be digitally connected, so we wanted to enable them to take part via the phone. And some of these findings have also been featuring in a policy briefing from the Liverpool Heseltine Institute, and it's really just to kind of give the background to this study. So in this study in the UK, we found faster deteriorations of people living with dementia. Care was severely affected. But so when the first findings started to emerge, we were contacted by collaborators, as I mentioned before, in those 4 other countries. So we have now been working with Poland, Italy, India, and Australia. And what we've done is we've culturally and linguistically adapted the topic guides for people with dementia and unpaid carers. And also in 3 of those countries, so in Poland, Italy, and Australia, they also conducted the survey. However, the interview component of this mixed method study seemed to be much more effective, and more people participated. So for this reason, I will share with you some of the emerging findings of the qualitative component of our 5-country study. And you see here as well when the data were collected. Now, obviously, each country has had and is having different waves of the pandemic, different types and different levels of restrictions. But all of the data were collected within around 9 months of last year, just to kind of give a highlight. And it sounds a lot, but we've had 126 interviews, and that's a lot of data to compare. So you'll only see a snapshot now of what we've been doing. There's more to come. Overall, one of the first things which has also been, I suppose, replicated from the original UK findings, we found that across countries, there were limited levels of access to support services, such as daycare centres, paid home carers, support groups, and support. So here you see a couple of quotes from different countries, different carers, illustrating that. For example, the Italian carer said she felt really abandoned, they couldn't do things anymore. But also what emerged in Poland in particular, that access to healthcare for people living with dementia seemed to be specifically affected. We haven't really picked up on that to that extent in the other countries, but that seemed to be a bigger concern for Polish carers and Polish people living with dementia. And I suppose this already starts to highlight some sort of cultural variations as well, how care is provided. But particularly, we noted that across the 5 countries, it appeared that India in particular, so all the Indian carers that participated in those interviews, or the vast majority of them, seemed to be very little affected by those by the restrictions, because in India the culture is more that people with dementia are being cared for within their own home. There might be some stigma as well if they were to access outside support. So effectively they were restricted to their own home, but this is where they take care of their relatives anyways. So they did not struggle as much as people in Australia, Italy, and the UK. And interestingly, we also found this to some extent, not to the same degree, but to some extent in Polish carers and Polish people with dementia as well, because it appears that there's still quite a big stigma surrounding dementia in the community, so that external support services, except obviously healthcare services, aren't very well utilized for Polish people living with dementia. So again, it's more about a family care being provided. And this has been really interesting to see. And it clearly shows, yes, the pandemic has had a huge impact on dementia care and the lives of people living with dementia and carers everywhere, but really to different degrees. And it was impacted on how care is provided prior to the pandemic as well. Now, we've also done a look at technology issues, obviously, because services have been provided slowly, but gradually more remotely. And we found, well, as here this quote kindly illustrates, nothing can replace contact with other people. And there have been lots of different focus about how services are provided digitally, but also, for example, when we've done the follow-up interviews in the UK, we've heard from people living with dementia in particular that it's a lifeline, but it doesn't replace it. And in fact, because people weren't able to attend face-to-face services for a long period of time, some of them really had poor emotional well-being. So, but we also need to consider, we are dealing here with, we're talking about people living with dementia. We're talking at some point, to some degree, about older adults living with dementia. So there might be the digital gap in the lack of understanding how to engage with technology, but also if we think about certain subtypes of dementia where people have visual problems, for example, it's really difficult to engage in a support group where you have lots of different Zoom boxes on your screen and you can't really see or recognize your peers in those different boxes. So there are difficulties and barriers to receiving good support via remote support. And the emotional impact of the pandemic. Now, I did mention before that there were cultural variations, but that doesn't mean that people weren't affected emotionally in all countries by this. So here you see a quote, for example, from an Indian male carer, the son, and he's talking about his father, and he's really struggling and irritated because he's just at home, and usually that person would go outside and go about their daily lives. And we've had that in all countries, really, the poor mental health and the poor mental well-being as a result of the sudden removal of daily routines. And as we've also found very early on in the UK data, we found across those countries, less so in India, because there was still obviously the family carer providing care, but to some degree as well, the deterioration of cognitive and physical health, so faster deterioration of dementia symptoms. Also, we've heard from people that their relatives were then struggling to engage with those daily activities here, as I've kind of indicated, making a hot drink or getting dressed, for example, or engaging with hobbies. But it's not only that, referring back to a couple of slides ago, it's the emotional impact. People were depressed about it, people living with dementia, so they didn't want to engage much in those activities anymore. And here you see a few more quotes from Australia and from the UK. For example, the Australian carer saying she was really worried, and the person retreating mentally and physically, just kind of illustrating again. And it's really concerning. Now, the data were collected in 2020, but it's still obviously relevant when a new wave or waves. So it's really concerning hearing that these have been the effects very early on in the pandemic, but what are the long-term implications of this globally? So to briefly summarize some of the key points, we did find across countries with some variations, as I pointed out, a lack of social support and social care for people with dementia and their carers, a really worrying impact on their cognitive and physical symptoms, which also we found specifically in the UK has led to faster entry to care homes because people were deteriorating faster. And also, as I mentioned, poor emotional well-being and increased carer burden because outside care was lacking. So unpaid carers had to take on those additional caring duties. And again, if we think about how long this is going on, it's of real concern. So just to kind of highlight lastly, a systematic review that some of the people from the original 5-country study are involved in, but also now collaborators from Germany and across the UK. We're looking into the effects of the pandemic on people with dementia and unpaid carers currently, and we're halfway through. But obviously there's lots of publications coming out. We're specifically looking at the health and mental health and cognition, social care access and use, and financial implications. And again, we want to understand the global picture of the evidence base, how dementia has been affected. And that's been all from me. Thank you very much.
Thank you so much for your presentation, Clarissa. I think we've all understood over the past almost 2 years now, just the types of impact that have been had on people and how this has been affecting people in different ways. But I think to quantify it in the way that you have with those in-depth interviews with people really helps to paint quite a stark picture of just how the extent to which people have been affected. I don't see any questions in the chat, and I'm just very conscious of time that we still have 2 presentations to go. So with your permission, I'm just going to move on. But again, I do encourage people to contact the speakers on the platform if you have any questions. I would like to introduce Anders Gustavsson from Sweden and Wiesje van der Flier from the Netherlands, who are going to present work that they have undertaken on European estimates on the number of people who are living across the Alzheimer's continuum. So please, the floor is yours.
Thank you so much, Owen. I hope you can hear me well. We are 2 presenters here today, so I will start and invite Wiesje in a few moments. We are going to present a study on the European estimates on the number of persons across the Alzheimer continuum. We can move to the next slide, and I can tell you about PAVE, Project Alzheimer Value Europe, which myself and Wiesje are part of. This is a consortium focusing on the challenges of value assessment and funding for Alzheimer therapies and diagnostics. And the goals are twofold. One is to compile evidence and educate stakeholders on this topic, and the other is to work out new solutions, how to improve the situation. There was a big group conducting this study that we will present today. Myself and Wiesje part of that, and this part is also funded by Roche and Biogen. I will ask now Wiesje to give a background to the study.
Thank you, Anders, and then please move to the next slide. And I think I'm preaching to the choir here when we say that Alzheimer's disease is really an enormous and growing burden to our society. And the most recent numbers issued by the World Health Organization come to an estimated 55 million of people with dementia in 2019, and 14 million when we would talk about Europe alone. And it's clear that these numbers are increasing over time, over the next decades. Most of the dementias are attributable to underlying Alzheimer's disease, are due to Alzheimer's disease, roughly 2 out of 3. And the global costs of dementia were estimated $1.3 trillion in 2019 and are still increasing. And this is huge. Next slide, please. So the two main issues concerned with the prevalence with the numbers of Alzheimer's disease is that mostly these diagnoses in these studies have not been confirmed by biomarkers. So we do think that roughly 2/3 are due to Alzheimer's disease, but we're not sure. And the second thing is that actually almost all prevalence studies focus on the dementia stage of Alzheimer's disease, and actually ignoring the pre-dementia stages. Because we now know that the largest part of Alzheimer's disease takes place before dementia. So you could think of the dementia, the mild, moderate, the severe dementia stages, as in fact late stages of disease, the largest part of which takes place before the stage of dementia. Prodromal AD, which is more or less equivalent to mild cognitive impairment, or MCI, where there are cognitive problems, memory impairments, but not yet impairment of instrumental activities of daily living. And even earlier than that is the preclinical AD, which is completely asymptomatic, or there may be very mild signs and symptoms such as subjective cognitive decline. But this is really the preclinical AD, where we do have AD biomarkers, but no signs or symptoms. And the issue here is that the estimates for AD dementia are actually not confirmed by biomarkers, so we do not know what the exact numbers are of dementia due to AD, and even more importantly, that the pre-dementia stages, both preclinical AD and prodromal AD, are not included in the estimate sizes of the AD population. And with that, I would like to hand over to Anders again to take us through our study.
Thanks, Wiesje. So we set out on this study with the objective to describe the available evidence of prevalence across all stages of Alzheimer's, and to synthesize this evidence into estimates of global number of persons across these stages. We also had a specific focus on potential target populations for preventive measures. And we did this by reviewing the literature, focusing on large meta-analysis, drawing data from multiple cohorts. These studies included both studies on clinical presentations or populations with clinical presentations, and other populations where biomarker data on Alzheimer's pathology were available. So we compiled this evidence and had a look at that evidence in a study steering group, and then we developed a simple model to combine this into global estimates across the continuum. There were essentially a handful of studies that were selected in the end for our model. Again, these are both separate studies on clinical populations, and others looking at Alzheimer's pathology in different populations. There are a few notable here. One is that we selected the old Alzheimer's Disease International study on dementia for dementia prevalences. Since that, there has been a new updated study from WHO, and we compared our findings with that study, and there weren't a great big deal of differences, so we kept the original study that we used. So combining all these different estimates from different studies into this simple model, we get the figure that we have here to the right, where you see an increasing prevalence over age groups, and also a difference between men and women. And we can put them on top of each other here. So you see the blue for AD dementia, orange for prodromal AD, and gray for preclinical AD, with an increasing prevalence again over age. We saw also other risk factors, including low education, genetic variants, particularly ApoE epsilon-4, and female sex, and then ethnicity as well. There was limited evidence of variation across countries, except for in general dementia. And I would say this is probably because it's only in general dementia where we have that evidence base to be able to show differences across countries. So for other stages, there is simply not enough evidence to show that type of variation. The last slide was on prevalence estimates, and when we combine those with the population sizes in different regions of the world, we get this somewhat different picture with a lot more persons that are women with Alzheimer's disease, and that is both because they have a higher life expectancy and also because they have a higher risk of Alzheimer's disease, at least in the symptomatic or AD dementia stages of the disease. You can see here also in younger populations, 50, 60 years, there are quite a lot of individuals with preclinical AD, despite the relatively low prevalence in these lower ages. They are so populous, so they become quite important when looking at the numbers of people. So taken together, you can see in the table there at the bottom right, 75 million people in larger Europe. This is a population of 299 million people age 50 and above, and out of those 75 million are on the Alzheimer continuum as defined in our study. So that makes a quarter of the European population above 50 years of age, the majority being women and most in pre-dementia stages of AD, 91%. And these 91% are important targets for preventive measures, as they are at risk of progression to symptomatic disease. As an example, in prodromal AD, about 2 out of 3 persons in prodromal AD are expected to progress to AD dementia within 3 years. So back to Wiesje again on conclusions of this study.
Thank you. Yeah, so what we showed is that when you look at Alzheimer's disease, the largest proportion of persons with Alzheimer's disease do not have dementia, but are in earlier stages of disease, prodromal Alzheimer's disease, preclinical Alzheimer's disease. And we do need further studies for providing precise prevalence estimates with particularly better insight in different risk factors and how these numbers vary across countries and regions. And it's really relevant to notice that more than 2 out of 3 of all the persons within the Alzheimer's continuum do not have any detectable signs or symptoms at all. So these individuals with preclinical Alzheimer's disease can only be identified with biomarkers, and this obviously needs a lot more of study, since we do not know whether all of them will actually progress to being symptomatic or that they may actually, some of them may be protective. But this is clearly of great relevance, as it provides a window of opportunity for prevention, and would also illustrate that we need easily accessible and scalable tests to identify these individuals. For example, blood-based biomarkers would be quite helpful there. So these numbers and this information is of big importance to inform policymakers and healthcare planners on the size of the population that would benefit from future therapies targeting Alzheimer's associated pathology. And this would primarily relate to prodromal Alzheimer's disease and mild AD dementia, so the early symptomatic stages. But it would also be very relevant to inform on the size of the population that would benefit from non-pharmacological prevention, for example, lifestyle interventions. And these would perhaps be primarily relevant for individuals with preclinical AD, and there are many of them. And this also illustrates that the size of the population that would be eligible for more robust detection and also timely diagnosis, and in the future, not yet now, but in the future, potentially screening programs. And with that respect, I think these numbers are really very relevant in while we're working all together towards a future where we can do more for individuals with Alzheimer's disease, where we can actually have precision medicine for Alzheimer's disease. And with that, I would like to end and show you the last slide with references, and hand back to the chair. Thank you.
Thank you so much to Anders and to Wiesje for that really interesting presentation. I think this is an issue which is increasingly it's been coming up again and again. When we did the study for prevalence of dementia for 2019 for our yearbook, we came up with the same identifying problem that, again, so many of the studies just didn't include this. And I think, as you've described, it's an issue that comes down to blood-based biomarkers, it comes down to diagnosis, it comes down to the resources and the facilities within countries to be able to do this. But as you say, I guess more research is needed in this, especially because this detection can be done, but we need to know what that means for people, because does it then progress to dementia or full Alzheimer's? So I think this is an area which is going to be developing, and they'll be very interesting in the coming years. I'm going to move on to the last presentation. I'm just aware that we have we're just slightly short on time, and I would like to make sure that our last presenters get the chance to present. So this is a pre-recorded presentation from Jonas Storgaard and Mai Myhre from Norway. They are a nurse and occupational therapist, respectively, who work in Almas House, and they're going to be talking about the knowledge service during the COVID-19 pandemic and the support that was given for people with dementia. So I will ask if the moderators could play their video, please.
Welcome to Almas House. We hope you all will join us on this visit and trip of learning. The everyday life for people with cognitive impairments or dementia can be very difficult. They might very often meet challenges in their homes. Everybody should be able to manage everyday life in safe surroundings.
It is a house or a flat with a bathroom, living room, kitchen, and a bedroom. This visit at Almas House will show you how surroundings, various devices and assistive technologies can make the everyday life of people suffering from dementia or cognitive impairment possible to manage.
Hi, is the video better for you now?
I'm fine. How are you?
Very good.
Yes, hello. We are happy to be here and to be able to present from the abstract we submitted about Almas House Knowledge Service during the COVID-19. My name is Mai Myhre and I'm a registered nurse, and I'm going to do this presentation together with a colleague, and her name is Storgaard, and she's an occupational therapist. We started this presentation showing you parts of a 3D film we made during the pandemic, and one of the technology we show in Almas House. You will find Almas House in Oslo, the capital of Norway, and this is a picture of Oslo city in the early winter time, like today. Almas House opened for visitors from October 2012 as a part of Oslo Dementia Plan. And the idea behind Almas House was to see and touch products and technology in a natural home-like environment. The flat shows also universal design and age and dementia-friendly environment, like use of lighting, colors, signs, and where to place furniture, and all this put into a home environment. Almas House is a service for the inhabitants of Oslo municipality and a knowledge center for the healthcare staff. So where are Alma and we in the organization? Almas House is a part of Center for Development of Institutional and Home Care Service Center, Oslo Municipality Healthcare Service, Home Care Service, and Nursing Home. Oslo Municipality has approximately 700,000 inhabitants, and almost 10,000 people have dementia in Oslo.
And Almas House has some employees. We have something called the Alma team, and this is us, 5 young ladies. We are trained staff and we are running Almas House. We are both occupational therapists, registered nurses, physiotherapists, and one with another background in dementia. We cooperate together with Norwegian National Advisory Unit on Aging and Health. We see ourselves as knowledge broker, and somebody told us that they saw us as knowledge broker. We are translating science. We're translating between research and practice, and between technology and the user. And the user can both be people with dementia, cognitive impairment, their relatives, and healthcare staff. And then we also try to tell the decision makers, developers, engineers about people with dementia's needs and their problems, and how they can use technology. And who comes to visit Almas House? We have 3 target groups. We have the audience, who are people with dementia or cognitive impairment, maybe their partner, children, grandchildren. We have students from various studies, basically all. Then we have the healthcare professionals, and this can be healthcare staff from nursing homes, home care service, and hospitals. We also have master students in Almas House, mostly occupational therapists and nurse students. And then we have the decision makers, and it can be both politicians, municipality doctors, the architects who build nursing homes, designers and developers. And then we also have Alma Contact. An Alma Contact is a health staff person who is a trained personnel, and the Alma Contact can come both from the healthcare, from the nursing home and the home care service. And they are trained to visit and use Almas House. So they could go here without us, Alma team, and they can be here together with persons with dementia and their relatives. They can also use Almas House as knowledge center for colleagues. Alma has a vision, and the vision is coping in safe environments. A few weeks in the pandemic, one of the Alma Contact, she called us and asked us please to open up again, because we have been closed down like the whole society. And the Alma Contact saw that the users she worked with, they didn't cope anymore. There was loneliness, they went to the hospital, and they didn't cope in the safe environments. So we would like to open up again.
So we saw that it was important that we were open and available where everything else was closed down. This to maintaining dementia as a public health priority, prevent sickness, cognitive and physical decline and loneliness, to be a support for the relatives, safety and security for all, and that people with dementia could live home with dignity. But we saw also that it was important to be supporting the healthcare staff. So it's almost like the picture when the ice has settled on the sea, the boat must still be able to get through, but maybe in a different or harder way. So almost an icebreaker. So to be open, we had to change during the COVID-19. We had to limit the number of people visiting Almas House according to the COVID restrictions. So before, maximum people in Almas House was 20, but after the COVID restriction, only 5 persons could visit Almas House. And the fact that we changed our routines, Alma could still be open and available to the inhabitants of Oslo. But Luna, can you tell us if we did some more?
Yes, we did, and you already saw it. We, as I told you, we already collaborated with Oslo Metropolitan University, and they asked us if we could make a digital film from Almas House. And of course we said yes. The film gave us, the Alma team and Almas House, the opportunity to reach our target groups in Oslo and Norway. Even though we also had a bit open, it gave us bigger opportunity. The Oslo Metropolitan University was collaborating with the Canadian University from before, so the film are subtitled in English. But we in Almas House have always also people coming from another countries, so now we are available for people around the world. The society is now starting to be open, and we have experienced that during the COVID-19. We have experienced that we were able to keep open despite the restrictions, and we had willingness to change, both us in the Alma team and our target groups. And then we had trust and acceptance to be opened from our management, and it was very important. We have returned to the condition as pre-COVID-19 now, with back to physical showings, but we're not going quite back, only almost, because we see that we still carry on the digital Almas House. We have requests from all over the world, and if they can't come to Almas House, we can use the digital film.
Yes, thank you for listening about Almas House, knowledge service during the COVID-19. You can now see us digital, but we hope that if you come to Oslo, you can also come physical, so send us an email. Thank you for having us, and we hope you all enjoy the rest of the conference.
Thank you very much to Lona and Mai for that really interesting presentation, and how they were able to continue to keep dementia as a priority during the COVID-19 pandemic, but also how you were able to maintain the service and offer that support, which, as we've heard from before, has been really vital to people during the pandemic, especially to people with dementia and carers. So it was really interesting to see how you did that, and especially, I imagine, for a lot of people, the digital aspect of that is particularly interesting and something that they would be keen to learn more about and to maybe to do themselves. I'm very aware that we've actually went over our time. There is another session as well, so apologies, I won't have time to follow up or to do more questions, but I just want to say thank you so much, and thank you to all of our presenters today. Thank you for bearing with us during our technical difficulties. I don't think it was just us that was affected. And I would just like to say, I hope that you enjoy the rest of the conference. And again, please make use of the opportunity to follow up with our speakers through the conference platform. So thank you, and I wish you a pleasant rest of your conference.